Welcome to this Building Research Acumen in Neuropsychology seminar. I'm Hetta Gouse. I'm a neuropsychologist based in the Department of Psychiatry and Mental Health at the University of Cape Town, South Africa. I have affiliations with the HIV Mental Health Research Group and the Neuroscience Institute. During this seminar, I will give a superficial overview of the dementias to orient you to the field. Dementias are complex, and each of them deserves a more in-depth discussion than what this seminar allows for. This may be something for future seminars. Dementia describes a condition in which there is a gradual, insidious, and relentless loss of cognitive function. There are several different types of dementia presenting different symptoms. This variability sometimes makes it difficult for the clinician to make a diagnosis of specific dementia. There's also the added problem of cognitive decline with increasing age. Frequently normal cognitive decline may mask early appearance of dementia because memory impairment, difficulty in name finding, and an increase in reaction time occur among the healthy aged. Because intellectual competence in older people may vary in itself, it can lead to people with poor intelligence to be misdiagnosed with dementia. The DSM-5 diagnostic criteria for dementia are evidence of a significant cognitive decline from the previous level of performance in one or more cognitive domains. And the cognitive domains are learning and memory, language, executive function, complex attention, perceptual motor, and social cognition. These cognitive domains are briefly discussed in the Neuropsychology What, Why, and How seminar in this series. The cognitive deficits. These cognitive deficits must interfere with independence in everyday activities. These cognitive deficits must not occur exclusively in the context of a delirium, and the deficits must not be better explained by another mental disorder, for example, depression or schizophrenia. Different types of dementia affect different brain systems and present with different clinical symptoms. Dementia associated with different disorders can therefore be distinguished from each other because these degenerative diseases have predilections for certain brain regions and show relative sparing of others. As a result of these distinct profiles of cognitive and behavioral change, different orders can be identified with a relative high degree of accuracy using neuropsychological assessment. Alzheimer's disease and frontotemporal dementia and its associated syndromes of semantic dementia and progressive aphasia result largely from degeneration in the neocortex and present as changes in mental function. Physical symptoms and signs are minimal or absent initially and typically emerge only later in the disease course. By contrast, in conditions that fall within the category of movement disorders, the primary site of pathology is the basal ganglia. Physical symptoms and signs predominate, and mental changes may be subsidiary or emerge later in the disease. Some disorders, for example dementia with Lewy bodies and corticobasal degeneration, may be characterized from the outset by a combination of cortical and subcortical features. Neuropsychological evaluation can aid recognition of each condition, but is particularly crucial in the cases of neocortical disorders such as Alzheimer's disease, for which neurological examination provides few clues. The table here summarizes the dominant sites of pathology in the brain, the dominant impairment, and how patients present neuropsychologically with regard to the different types of dementia. Mild cognitive impairment, or MCI. All people develop some cognitive fall-off as they age. It can be difficult to distinguish between normal aging and pathological decline. Neuropsychological testing can indicate pathological decline when a patient's testing results are compared to normative data. Cognitive decline that typically accompanies normal cognitive aging involves decreased efficiency in information processing in several areas, including speed of information processing, reaction time, working memory capacity, short-term memory, executive control, and verbal fluency. Visuoperception, visuoconstruction, and spatial orientation also decline with age. Mild cognitive impairment represents a decline in cognitive performance greater than expected for that person's age, but not sufficient to meet criteria for a diagnosis of dementia. Criteria for mild cognitive impairment are concerns regarding change in cognition, impairment in one or more cognitive domains, preservation of independence in functional abilities, meaning patients can continue to function on a daily basis, and that the person is not demented. In Alzheimer's disease, the earliest presenting symptom is usually memory difficulties. These may include remembering appointments, remembering recent events correctly, asking questions over and over again, and misplacing objects. Memory for events that happened in the remote past are usually intact, and it is often said that patients with Alzheimer's disease live in the past. While patients may have some awareness that they have memory difficulties, they may underestimate the magnitude of this problem, since they themselves forget that they had already asked a question or done something. This is why it is important to get collateral by speaking to someone who is close to the patient. You will note that there is usually a difference between the collateral report and what the patient says, and this is very valuable information. On testing, memory difficulties are borne out by performance on tests of episodic memory, such as list learning, story recall, face and object memory. While patients might show some benefits from cueing and recognition, this is usually limited. And when delayed recall testing is done, patients will typically not be able to recall the information, suggesting that the problem is not one of initial attention and registration of information, but rather a memory impairment. The difference between visual and verbal performance reflect the greater emphasis of atrophy in either the right or left medial temporal lobe. Patients may also present with poor working memory. This is usually seen in the way that patients lose their train of thought. The tester may note that the patient requires constant repetition of test instructions, and on testing, the patient may show a reduced digit span. It is generally thought that working memory difficulties in early-stage Alzheimer's disease is due to central executive impairment or problems in divided attention, because patients struggle to cope with several tasks at the same time. The most common language symptom in Alzheimer's disease is a problem in word finding. The Boston naming test is usually used to assess this. Word finding difficulty is usually most evident for use of proper nouns, such as remembering people's names. Conversational speech may become halting because of word finding difficulties, and patients may not complete sentences because they lose their train of thought. Patients may make paraphasic errors, for example, use the word drive instead of the word car, and they may develop stuttering speech. These difficulties may extend to spelling and reading and writing, as well as calculation. Word-finding difficulties are ascribed to impaired semantic memory. While comprehension largely remains intact, complex sentences may be difficult for patients to follow, and for this reason, people with Alzheimer's disease may avoid socializing. Impairment of perception and spatial skills may be noted based on reports of minor driving accidents. This happens because of poor spatial judgment. Patients may also become lost, first in unfamiliar surroundings, and then in familiar surroundings. This may also affect the patient's ability to get dressed, in that they may put their clothes on incorrectly. Constructional tasks, such as the clocks drawing and copy of simple line drawings, are very sensitive to spatial difficulty in these patients. With regard to praxis, patients may not be able to use symbolic gestures, for example, waving or saluting, and manipulating objects, for example, folding clothes. With regard to executive functioning, Performance failure may be due to the patient's problems in memory, language, perception, spatial functioning, or praxis. But the memory difficulties that the patient presents with far outweigh the executive functioning presentation. Gross character change is not associated with early and middle stage Alzheimer's disease. Patients present with a good social facade that may mask their cognitive difficulties. Behavior changes that may be seen in Alzheimer's disease are increased irritability, anxiety, low mood, loss of confidence, and patients may be less outgoing than before. Vascular dementia is the second most common dementia. Neuropathologically, the dementia can arise from ischemia and hemorrhage, or from cerebral injury caused by cardiac arrest. Onset of the symptoms is abrupt. Vascular disease is a risk factor. Features include memory difficulties. However, these patients benefit from prompting and recognition, where in contrast, Alzheimer's disease patients do not. They also present with general intellectual decline, decreased executive functioning, and slow processing speed. The problem with regard to memory in vascular disease is a problem of registration of information rather than retention of information. Frontotemporal lobar degeneration is an umbrella term for pathologically linked clinical syndromes that result from atrophy of the anterior hemisphere of the brain. These include frontotemporal dementia, which is a disorder of behavior and executive function, progressive non-fluent aphasia, which is a disorder of expressive language, and semantic dementia, which is a disorder of conceptual understanding. These disorders have specific anatomical locations in the brain, as is illustrated in the table that I showed earlier. These syndromes present mostly in people in their 50s and 60s. They are progressive, and the course lasts approximately 8 years. In frontotemporal dementia, altered behavior is the dominant feature. Patients are disinhibited and socially inappropriate. They neglect self-care and personal responsibilities without showing any concerns for it. Their character is radically altered. Their socially inappropriate behavior may include doing things like drinking wine from a bottle in the restaurant or wandering out naked without any concern for doing that. With regard to cognition, they have impairment in a range of frontal executive skills: abstraction, planning, organization, attention, and mental set shifting. They may also have severe perseveration. Perseveration is an action that a person can't stop once they have engaged in it. For example, in this image here on the slide, the instruction is to copy the model exactly. But you can see that the patient here couldn't stop after 2 loops and continued on. With regard to language, patients have reduced speech output, that is, they speak less. Echolalia, meaning that they meaninglessly repeat what is said to them. Perseveration, verbal stereotypies, which is a repetition of verbal utterances. For example, they may say ba, ba, ba. And ultimately, they stop speaking completely and become mute. With regard to memory, they present with a frontal type impairment that is similar to vascular dementia and not like the memory impairment that you see in Alzheimer's disease. The problem here is again registration of information rather than retention of information. In semantic dementia, patients have a multimodal loss of conceptual language. At first, patients may lose the meaning of words. For example, they may not understand what you mean when you say the word happy or when you ask them, "Are you happy?" and may say to you, "What is happy?" Patients, however, continue to speak fluently and without effort or grammatical or phonological errors. Similarly, Patients may have difficulty attributing meaning to non-verbal concepts, for example, smell or taste. Because patients present with memory difficulties that look similar to Alzheimer's disease, they may be misdiagnosed, but these patients do not have other symptoms associated with Alzheimer's disease. For example, they do not get lost, they can perform the activities of daily living, and they can keep track of time. With regard to behavior, patients tend to become egocentric. Their world becomes very narrow. They may develop a strict daily routine. They tend to be time-bound and preoccupied with a narrow range of interests, to the degree where they may restrict their food intake to a narrow range. In progressive nonverbal aphasia, patients have marked problems with expressive language, while their word comprehension is well preserved. The predominant feature is anomia, where patients can't recall the name of objects. Patients have difficulty finding words that remain in their vocabulary. They may have effortful speech, agrammatism, and phonological disturbances, incorrectly forming words. Patients also have difficulty in using symbolic gesture, so it is difficult for them to supplement their language impairment with gestures to explain their speech. Effectively, patients become mute. Dementia with Lewy bodies is the closest to Alzheimer's disease and shares clinical features of both Alzheimer's disease and Parkinson's disease. Core defining features are cognitive impairment and mental fluctuations, visual hallucinations, and Parkinsonism, which is a movement disorder. Dementia with Lewy body disease present like Alzheimer's. However, attentional deficits and perceptuospatial difficulties are more pronounced in Lewy body dementia, and memory impairment is less severe. A striking feature of Lewy body disease is fluctuation in the patient's mental state, with a person having good days and bad days, and also with fluctuations in a single day where the person may be more lucid and like themselves, interspersed with periods of confusion. The other core feature of Lewy body disease is visual hallucinations. These are vivid and often include people and animals. Patients can describe them in detail, and they are mostly not afraid of these hallucinations because they are non-threatening. So they're quite different to what you may hear from patients who have schizophrenia. For example, an elderly lady we recently saw in the memory clinic was hallucinating children. She would see them playing in front of her and sometimes try to have conversations with them. These hallucinations, she was so taken with these hallucinations that she even left out sweets for the children. It is now generally accepted that Lewy body disease and Parkinson's disease dementia are the same diseases. So what do we know about dementia in sub-Saharan Africa? The aging population in sub-Saharan Africa poses an impending crisis, with the number of people with dementia expecting to surpass 7.6 million people by 2050. That would be 250% more than we have at the moment, according to the Alzheimer's Disease International. More studies are needed for us to understand how risk factors affect Africans and how we can prevent dementia on the continent. While risk factors for dementia like age and gender, genetics, vascular disease, education and literacy, early life circumstances, lifestyle and behavior, psychosocial aspects, HIV dementia, and environments are global, socioeconomic and genetic differences may impact on dementia risk, and it is important that we understand how that affects Africans. I highlight a few factors that we need to consider, and I suggest that you go read the full report by the Fogarty International Centre linked on this page. Gender and increasing age are risk factors that have been mostly closely associated with dementia in sub-Saharan Africa. Studies found that women have a 2 to 8-fold increased risk of dementia. This is attributed to their longevity compared to men. While education is considered a strong mitigating factor in high-income countries, with studies supporting the cognitive reserve hypothesis that education may impact onset of the symptoms of dementia, results in sub-Saharan Africa have been inconclusive. Some studies have found an association between low education and dementia, and others have found no interaction. When an association has been found, it's often greater for women than for men. Childhood circumstances such as birth weight and nutrition and their potential role in dementia have also not been well researched in sub-Saharan Africa. With regard to HIV dementia, prevalence and risk factors of HIV-associated neurocognitive disorders are being studied in sub-Saharan Africa, but most of the research relates to young adults. Research in high-income countries have shown that long-term use of antiretroviral therapy is increasingly associated with cognitive impairment and dementia as people live normal lifespans. This is likely to be mirrored in sub-Saharan Africa as the population living with HIV continues to age. Data on HIV-associated neurocognitive impairment or neurocognitive disorders in older Africans is needed. In conclusion, dementias affect different parts of the brain and present with different cognitive and behavioral symptoms. Neuropsychological testing can distinguish between the dementias and inform treatment and rehabilitation of patients and their environments. Excuse me. Neuropsychology is important for distinguishing between the dementias and is important for treatment. And lastly, we have little information on the rates of dementia and prevalence of types of dementia in sub-Saharan Africa, risk factors for dementia, and what we can do to mitigate risk factors for dementia in sub-Saharan Africa is also needed. These are the resources that I used for this seminar. I also recommend that you check out the Navigating Neuropsychology podcast for general information on neuropsychology and also the dementias.